I'd like to now introduce our next speaker for this morning, Professor Peter Gøtzsche. Now, Peter is a great titan in the clinical research community, least of all for co-founding the Cochrane collaboration in 1993, and he is now director of the Nordic Cochrane Centre. He's also Professor of Clinical Research Design and Analysis at the University of Copenhagen and has published over 70 papers, and he's also published in the big 5 medical journals, which very few people have actually managed to achieve. And he's been cited a staggeringly 15,000 times. He is author of the following books: Rational Diagnosis and Treatment, Mammography, Screaming, Deadly Medicines and Organized Crime, and his most recent book, Deadly Psychiatry and Organized Denial. So please join me in warmly welcoming Peter Gøtzsche.
Thank you so much. Well, it was difficult to find the right title. I had 18 different proposals before I settled on that one, which I feel is the right one. Okay, I'm a researcher, and the views I present today do not represent those of any organization. They're, of course, mine, but they are based on science. They don't come out of blue air, thin air, that's what you call it. Now, it's depressingly easy to get a diagnosis of depression. In America, they say that 10% are depressed at any given time, but it doesn't take much to be depressed. If you have less interest in doing things you usually do in 8 days out of 14, plus one additional symptom, which can be difficulty sleeping, difficulty eating or overeating, which most Americans do, or running around more than usual, which could be because you just got a big grant for your research. But apart from joking with it, it's that serious. Imagine a boy whose sweetheart left him. How do you think his next 14 days will be like? Miserable. He can't sleep, he can't eat. Bingo, you have a diagnosis of depression. What happens next? He will likely get a pill if he looks up a GP or a psychiatrist. Now, one of the things that have been criticized a lot about DSM is how they look on bereavement. In the DSM-3, you were allowed to feel sad for 1 year before you got a diagnosis of depression. Then it became 2 months, and then 2 weeks. So I wonder, why not 2 days in the next edition? And of course, doctors are not like that. Do you really think that they sit with a sad person and say, well, let me look up in the DSM? No, you need to wait another 10 days before I can give you the pills. You will get the pills immediately. That's how it works. And why cannot the psychiatrists get enough? I hear them complaining about they have too much work to do. Yes, because they turn a lot of temporary problems into chronic ones with their drugs. Of course they have too much to do. If they use drugs far less, I think we would have enough psychiatrists. Now, do they have any benefits? There was a huge FDA meta-analysis of 100,000 patients in placebo-controlled trials. Half of them were depressed. And what the FDA found was that 50% responded on drug and 40% on placebo. Now, when I tell psychiatrists that these are poor drugs, then they say, well, they are perhaps not that fantastic, but then the patients benefit from the placebo effect. This is not true, because to know what the placebo effect is, you need what? An untreated control group. If you don't do anything, most people would feel better after some weeks. That's not a placebo effect to do nothing. So what happens in a placebo group is not a placebo effect. Very few people understand this elementary methodology. It's not. Okay, but is the effect correct? No, it's not. The effect is measured on highly subjective scales like the Hamilton Depression Scale. So one of my senior researchers collected all trials in the world literature in all diseases that had a blinded and a non-blinded observer. And why did he do that? Because these trials are not adequately blinded. Most patients and doctors will know whether an active drug is used or placebo, because active drugs have side effects, dry mouth, blurred vision, whatever. So the blinding is not good. So therefore he wanted to see what if there is no blinding, what happens? Well, what happened was that the effect was exaggerated by 36% on average, measured as odds ratio, by the non-blinded researchers. And these trials mostly use subjective outcomes. You don't blind a researcher if you are studying death, of course. That's not necessary. Now, what if the blinding has been broken for all patients in the antidepressant trials? Then the effect is 0. But it doesn't need to be broken for everyone, just to quite few ones. If it leads to misclassification of the outcome, then the 40% becomes 45, the 50% becomes 45 if it is broken in rather few people. So there is no effect. Here is one of the most important Cochrane reviews ever made. It's made by Joanna Moncrief, psychiatrist here in the UK, and her colleagues. Since these trials are poorly blinded, they looked at trials that had actually been blinded, namely by adding a substance to the placebo that gives you side effects. This is called atropine. It gives you dry mouth, like antidepressants, so it's a good thing to do. And what did they find? Omitting the trial with an implausibly large effect, they found a standardized mean difference of 0.17, which I converted to 1 on the Hamilton scale, which goes up to 52. That's nothing. The effect is gone. A German psychiatrist looked at what is the minimum change that can barely be perceived by people. That's 5 to 6 on this scale. So 1 is actually nothing. And the bare minimum that can be perceived as a change is not clinically relevant. Because you can see light at the end of the tunnel, it doesn't mean there is enough light to read a newspaper. And you can see the same about these bare differences, minimum differences people can perceive. Now, why were the trials so old? They were from the 60s mainly, because placebo trials are done by the drug industry. They are not so foolish that they put something into the placebo, because then we could all see that the emperor has no clothes. Then they couldn't sell drugs to us. So these are the type of trials we need badly, also in psychiatry. But even those trials that were not adequately blinded, what did they tell us? They were biased, but what did they tell us? In children, the psychiatrist said that, well, there is some minor effect, Hamilton of 2. But what did the children say? Hamilton 0.4, 5 times less. And there are other meta-analyses of these trials. They all show about the same. What about the old drugs? And in adults, not children, like amitriptyline, what did the psychiatrist say? Again, an effect of 0.25, which is really nothing. And what did the patients say? They don't work at all. Now, here is an important meta-analysis of 2 drugs, fluoxetine and venlafaxine, done by an American statistician who receives a lot of industry money and produces some very strange research again and again, not always completely honest. But here he wanted to see how quickly do patients improve when they get antidepressant drugs. And what you can see is that they all, on average, they were severely depressed because they had a Hamilton of 21. How long did it take before they came down to about 13, which means mild depression? Well, around 4 weeks or a little longer on drug. How much longer did it take if they got placebo? About 1 week. These trials were not adequately blinded. If they had been adequately blinded, the placebo group would have come to the same point in a couple of days, a matter of days. Is it really worthwhile to use drugs with a lot of harms to gain a benefit of a couple of days before you arrive at the same level of depression? I think definitely not. So everything I have, not everything, of course, there's a lot of flawed research, but the good research I have looked at tells me the same story. These drugs likely don't work for depression. It's all a fata morgana. Do you know what that is? No, it's out in the desert when you think there is a lake, but there is nothing. Mirage, that's French. I didn't know English people could speak French. All right. So my scientific conclusion is inevitably these drugs don't work. What we see are mirage, not miracles. And what about if you ask the patients, if the drugs really produced more benefit than harm, then the patients should stay on them more than they stay on placebo. That's logical. They don't. They leave the trials as quickly on drugs as on placebo, so they don't work again. After only 2 months, half of the patients have stopped taking the drugs. And this is in trials where psychiatrists, often on an industry payroll, they have an incentive of telling the patients, you must stay on the drug, because if they don't, they might not get paid. Because sometimes the payment is dependent on that they carry through the whole trial. And what did the psychiatrists think about antidepressant drugs when they first came on the market, the newer ones, I mean, the SSRIs? Well, the first big one was Prozac, which the German drug regulator deemed totally unsuitable for the treatment of depression. And when Eli Lilly's director in Sweden presented fluoxetine for Swedish psychiatrists, they laughed him out. How can you ever think you can get this terrible drug approved? But then he found out who the guy was who was going to write a report to the Swedish authorities about Prozac. And already at their second meeting, that guy, Anders Forsman, he said how many dollars it would cost to write a positive report about a drug he had laughed out some weeks earlier. This he did, and he did a great career after this corruption. He became assessor for the country of Sweden in legal matters, in psychiatric legal matters. So you can get away with it. Many doctors and patients think antidepressants work, but why is that so? It's because you are not well. You do something, some weeks later you are well. Then you make the error of thinking that's because of the drug. You confuse the spontaneous healing that takes place. So when psychiatrists in debates with me say, according to my clinical experience, these are very good drugs, I think your clinical experience is worth absolutely nothing because you don't know what would have happened if you hadn't done anything. There's no control. You can also ask, Hamilton scale has been much criticized. Why do we treat people with depression? To get them back to work and save relationships and all that sort of thing. Do they work on that? There are thousands of trials of antidepressants. I have never seen such a positive outcome in any of them. So either it has not been studied, or it was, and it was pretty negative and buried in company archives. What about sexual problems? They actually caused sexual problems in half of those treated who had no sexual problem before they started an antidepressant drug. Does that save intimate relationships that you destroy people's sex life? I don't think so. And an FDA scientist found out that the drug companies are routinely putting the blame on patients and their so-called diseases and not on the drug. For example, when females couldn't get orgasm, it was coded as female genital disorder. It's your problem, it's your fault, not our pill's fault. And Eli Lilly said only 2% become sexually disturbed, but there is good research. Here is a Spanish study. 60% of people who had a normal sex life became sexually disturbed. Please do not interrupt me while Do not interrupt me while I'm talking, please.
So sorry.
Please, there will be questions afterwards. I have planned for this very carefully. Could you be quiet? So, decreased libido in 60% of the patients, delayed orgasm or ejaculation in 60% of the patients. So actually the drugs do something to prevent a man from having ejaculation. That's pretty strong stuff. Erectile dysfunction or decreased lubrication. Well, when I lectured for Australian child psychiatrists half a year ago, one of them said he knew 3 boys who couldn't get an erection the first time they were about to have sex. They were on antidepressant drug. All of them tried suicide after this experience. So what we do to people is really serious. How could they think it was the pills? They thought it was themselves that was the problem. That's what patients typically think. Some patients yawn during orgasm. That's not the most fantastic way of starting a new relationship. You can yawn later, but not during climax. What about abstinence symptoms, which are usually called withdrawal symptoms? For citalopram in the UK, for example, it says that in clinical trials, about 40% of patients experience, now it's called discontinuation symptoms. You don't call a spade for a spade. You should do that in psychiatry. So then they recommend, with a tremendous British understatement, that the dose is gradually reduced over a period of at least 1 week. Some of you in here will know that it can take years, and some of you will never succeed. You will be hooked on the drugs for the rest of your lives. I had a PhD student who found out that the withdrawal symptoms were actually pretty much the same for benzodiazepines and SSRIs, and they were not described as dependence for SSRIs. Why? Because the American psychiatrist on company dollars introduced a new version of what does it mean to be dependent just before Prozac came on the market. It must have been worth billions for the drug companies. So now I hear psychiatrists telling me they don't become dependent on SSRIs, they just need to be educated that this is not a problem. That's what psychiatrists generally say. And then they also say, you don't become dependent on SSRIs because dependence means that you should crave higher and higher doses. And then I say, great, then no one is dependent on cigarettes because they smoke 20 every day and have done that for years. No dependence there. Great, we can stop smoking tomorrow. For patients knows what it is about. When you ask patients, half of them will tell you it's difficult to stop SSRIs. Now, what does the UK drug regulator say? Oh, they're not addictive, they said 10 years ago. But the same year, the WHO actually published a report that noted that 3 SSRIs, fluoxetine, paroxetine, and sertraline, were among the top 30 highest-ranking drugs for which drug dependence had ever been reported. And now we're including morphine and other opiates. In the same year, GlaxoSmithKline, in small print, revised its previous estimate of the risk of withdrawal symptoms from 0.2% to 25%. That's a 100 times increase. They surely didn't publicize this and say, sorry, we are wrong, we have fooled you. It was in small print in the patient information. Now, Eli Lilly wanted to show that their drug is better than other drugs because fluoxetine has a metabolite with a half-life of 1 to 2 weeks, which is, they think, is active, okay? So they still have drug in their blood after 1 to 2 weeks. So Eli Lilly thought that if you suddenly stop the drug and put placebo in the pills 4 to 24 months after patients had become well, then they would probably develop worse abstinence symptoms on sertraline and paroxetine that have a short half-life than on fluoxetine. This was exactly what happened. If you look at the other drugs first, then you can see the withdrawal symptoms. They didn't know when the placebo period came, of course. This was blinded. So the withdrawal symptoms included worsened mood in about 1/3, irritability 1/3, agitation 1/3. What does this mean? Agitation can be a euphemism for akathisia. What does akathisia do? It increases the risk that patients commit suicide and homicide. It's very, very serious. So what Eli Lilly showed was that these drugs are very dangerous if you stop abruptly. And also Hamilton increased by at least 8 in 1/3 of patients on sertraline and paroxetine. What does that mean? That means that you could say now these people had become depressed after they had been well for 4 to 24 months. What is the likelihood that a person who has been well for so long becomes truly depressed in just one random week? Maybe 1 in 100. It's not 1 in 3. So what you see here is proof that withdrawal symptoms include depression. Then doctors will tell you that you are still ill or your depression came back, so now you have to go on forever on these drugs. But how can you distinguish between an abstinence depression and a true depression that would have occurred at any rate? You can do that very often by giving people the full dose. Then, within a matter of hours, many people will feel considerably better. You remember the curve I showed you before? It takes weeks before people become better. So if they become better in a matter of hours, it's a false depression. It's caused by the drug, as Robert said so eloquently. It's not caused by your disease. It's the drug that causes this. Now, I got this data from Finland. If you put 100 people on an antidepressant drug in Finland, then 5 years later, almost half of them are still on an antidepressant drug. Not necessarily the first one, because if you're still feeling bad, then the psychiatrist might say, then we'll try another one. Although that won't help either, because none of them work. But that's what people do. And then what does this mean? In the old days, when we didn't have these terrible drugs, a depression didn't last that long. It didn't last 5 years. It lasted some months, and then not very many got a return of a depression within the next year or two. So what this curve illustrates you so beautifully is, I'm sorry for saying this, legal drug addiction. That's what this curve means. Yeah, I think it's clear enough. And about half of the patients have been told, sometimes 80% have been told about the chemical imbalance, and you know that this is all wrong, so I don't need to say more about this. What about the ultimate outcome that we want to prevent when people are depressed, namely suicide? Do they work for this? No, they don't. The FDA asked the manufacturers to go through their files and report to them the number of suicide and suicide attempts, suicidal thoughts, and so on. And when the FDA published their internal report, they said that antidepressants increase suicidal behavior till age 40, and when you're older, it looks like they might protect you, actually. But these data, when they were published, they looked much better for the drug industry. Because now the FDA said, well, it's only risky up till age 25, and after that it's fine, you are on the right side of not harming people. So do they stop harming people at your 25th birthday? Of course they don't. And these data are completely wrong, and I will tell you why. Now, in the FDA's big analysis, there were only 5 suicides in 50,000 patients. That's 1 per 10,000. I found minor materials on drugs that were included in the FDA analysis where there were far more suicides. For example, you can see 9 suicides in just 7,000 patients on fluoxetine. That's 13 per 10,000. Up here, 14 on fluoxetine, 17 on paroxetine. And even worse, the man who was in charge of FDA's big analysis, Thomas Logren, he said in 2006, there's only one suicide per 10,000. That's the first line up there. But 5 years earlier, the same man went into the trials in FDA's possession and now reported 10 per 10,000, namely 22 suicides in 22,000. I mean, how can the same man report only 1/10 the number of suicides 5 years later? Because the FDA took great care not to embarrass the drug industry. They told them to go back and look what they could find. But the drug industry had already cheated on the FDA earlier. So this is like telling a criminal, go back to the scene of the crime. We won't send any police detectives. Just tell us what you find. Then come back and report to us. We won't check you. We'll believe you, of course. You're an honest person. That's what the FDA did. So I think there's likely to have been 15 times more suicides on active drug than the FDA reported. That's a pretty big error, 1,400%. And one of the tricks FDA used was only to count events occurring within 24 hours after stopping drug. You have just learned it's very dangerous to stop a drug, okay? So I'll tell you what this means. But another was that Eli Lilly and other drug companies very early on told the clinical investigators, if the patients become agitated or get akathisia, use a benzodiazepine or chlorohydrate or something to calm them down. What does that mean? You remove some of the suicidality because you calm people down. It also means we don't know what the effect is of an antidepressant if they have used more benzos in the active group than in the placebo group, because benzos also work for depression. Can you see that? So this whole trial literature is totally unreliable. And many suicidal events had been coded as something else, like admission to hospital or emotional lability, or left the trial, but the poor guy was going to kill himself, but we didn't learn about it. And only people at very low risk of committing suicide were recruited for the trials. Now, if the drug companies truly believed that these drugs protect against suicide, do you think they would have had this clause, no, we won't have anybody who is at risk of suicide in our trials? They wouldn't. If you study a cardiovascular drug, you don't say, we don't want anyone in our trials that don't have any risk of getting a myocardial infarction, a heart attack. You don't do that. Now, there are two big flaws in all psychiatric drug trials. First of all, as Bob has told you, you take patients already in treatment, then you may have a short washout period of 1 week or less. And if the patient gets very bad in this period, typically the patient is not randomized, okay? So then you get a false impression of the drugs. But not only that, you can get abstinence symptoms after the first week. So if you become suicidal here and it's caused by abstinence, then fine, then your drug looks better, because in the other group, you don't have the same abstinence symptoms. So these trials are terribly flawed. And then, conveniently, events after treatment are ignored, and I'll show you what this means. Namely, sertraline. We're not talking about children. Everybody knows that these drugs are dangerous for children, but many psychiatrists think that they protect against suicide in adults. They don't. Now, this is in adults, sertraline. Suicides and suicide attempts. The FDA analysis that only looked at events up till 24 hours after the randomized phase stopped, what did they find? A little decrease in suicidality, not much, and not significant. Now, when Pfizer looked at their own trials, it looked far better. Now, our drug halved the risk of suicide or suicide attempt. Great. But Pfizer was a bit careless, because they also looked at what happened if we look at up till 30 days after they came off the drugs. Oh, that wasn't good, because now sertraline increased the risk of suicide by 50%. So you can go from a halving increase of 50% just by including a longer follow-up period. Independent British researchers that had access to the data at the drug regulator also found that sertraline seems to increase the risk of suicides in adults. It wasn't quite statistically significant, but it was a doubling. You should not worry about whether things are statistically significant. I mean, one person that falls out of an airplane and dies, that's not a statistically significant death, it's just one. When we look at harms, we should forget about these p-values and statistical significance. We should look at what do the point estimates, what story do they tell us? Now, David Healy had access to company files because of court cases in the United States, and he found out that if somebody became suicidal during the washout period, it was added to the placebo period with the argument, well, they didn't get any drug, okay? And if they became suicidal after they came off the drug, it was conveniently removed and added to the placebo group because, well, they didn't get any drug, but it might have been caused by the drug because of abstinence, but they were added to the other group. Pfizer, GlaxoSmithKline, the big earner to your national economy in this country, Eli Lilly, they all did the same. This I call cheating. Now, what about people at my age? Well, they seem to be very harmful, antidepressants. There is a beautiful British study where patients were their own control. So in one period, they didn't get a drug. In another period, they did get a drug. So it was the same patient. And what happened? Well, if you treated just 28 people for 1 year, you killed one of them with an SSRI. That's a death rate of 3%. This was so unbelievable to me that I wrote an email to the first author and we exchanged views, and there are more studies than hers. And actually, I must say that they are dangerous, very dangerous in the elderly. And we know some of the mechanisms because elderly people tolerate psychiatric drugs very poorly. Everything that affects the brain, they tolerate poorly. So they might fall, lose balance, fall, and break a hip. What does that mean? 1/5 of people who break a hip will be dead within 1 year. That's one of the mechanisms. There are more mechanisms, but this is one important one. So I believe that this about, well, GPs and psychiatrists don't even keep antidepressants out of reach of children. It should be forbidden to use these drugs in children. They drive them into suicide. But actually, I think they should be taken off the market because they don't work and they cause a lot of harm and produce a lot of drug addicts. Why not take them off the market? That would be far better. And then people say, what's the alternative? What's the alternative to antidepressant drugs? Simple. No antidepressant drugs. How? I mean, people always start arguing, well, psychotherapy isn't always that effective, and it depends on whether the psychotherapist is good or bad, and yes, all true. But psychotherapy is another discussion. The alternative to drugs is no drugs. It's very easy. We would have far healthier and long-lived populations if we said no to psychiatric drugs. Now, Violence submitted to the FDA reports of that. 400 of them were homicide, and look that antidepressants, sedatives, hypnotics like benzos, ADHD drugs were particularly often reported among the reports of violence and murder. These drugs seem to be dangerous. Now, an Australian forensic psychiatrist studied 10 people that had mutations in their liver, which I think roughly 10% of people have, which gives them a wrong concentration of antidepressants in their blood. And look what happened. First of all, antidepressants are used for all kinds of foolish, non-existing reasons, like sister had a car crash, husband was drinking, I had difficulty with relations, or anxious about not making enough money. That's not an indication for an antidepressant drug. And what happened? Well, killed teenage daughter in toxic delirium after 3 days. Violent akathisia predisposes to murder for 14 days. Killed father 4 days after he ran out of pills. Abstinence symptoms. These people are not themselves. They act in out-of-character fashion. And it goes on like that. You don't need to see all of this. It's very, very sad. Harassment at work, you don't use antidepressants for that. All 10 people were able to stop taking antidepressants, often against their doctor's advice. Despite these horrendous acts, the doctors still lived in their fantasy world and felt these drugs are good for you. They were against them coming off them. But they did come off them, and what happened? they actually became themselves. This is a very, very sad story about what we are doing to people with our drugs. So, Bob mentioned this briefly, that there are these so-called withdrawal studies where people have been treated successfully and then you randomize to placebo or to continue treatment. And these studies are seriously flawed. It cannot be said often enough, because you introduce a cold turkey in the placebo group. Some people in schizophrenia trials have committed suicide when they were exposed to a cold turkey. And these suicides were not reported in the trial publications. They were gone. This study has already been mentioned. This is the only one I know about where there was a long follow-up after a randomized phase, and you know that in schizophrenia, more people had actually recovered if you reduce the dose or stopped altogether. And actually, 11 had stopped in the dose reduction group, only 6 in the active maintenance group, and also they used more drug in the maintenance group, and yet the result was better in the drug with discontinuation group. Now, a little about psychiatric deaths. I have tried to estimate how many people do these drugs kill. It's not easy. The randomized trials are totally unreliable. Therefore, I used randomized trials in dementia, arguing with myself, these old people likely were not in antipsychotic treatment before they received one. So no abstinence symptoms. And what did that show? It showed that if you treat 100 people with dementia with an antipsychotic drug for a few weeks, you kill one of them, compared to placebo. For the other drugs, I didn't have good randomized trial evidence, so I needed to find good observational studies. So you can criticize my estimates, but these are the best I have. In those age 65 or above, more than 500,000 deaths annually in the USA and Europe. This makes psychiatric drugs the third leading cause of death after heart disease and cancer. Isn't it time that we do something? And likely all drugs can cause chronic brain damage, and they often lead to addiction. And what I call psychiatrist silverbacks on drug company payroll have helped the companies hook more than 1 million patients worldwide on drugs most of them didn't need. And when problems arise, they typically say, blame the disease, never the pills. So antidepressants, don't use them. ADHD drugs, don't use them. They are harmful. Anti-dementia drugs, don't use them. Even in these flawed, non-blinded trials, the effect is so small that it has no clinical relevance. And they have a lot of harms, these drugs, so they shouldn't be used. Antipsychotics, 8% of current usage at most. I've actually come to the point where I say, why not drop them altogether? Because if you have an acute painful psychosis, benzodiazepines are good drugs. They calm people down faster than antipsychotics do in randomized trials. These trials are not very good, but there are 14 of them in a Cochrane review. So I'm not sure we even need antipsychotics. Throw them out to the fishes. Oh, then people will eat the fishes, I know, but so I think we need only 2% of current drug uses at most. So we have an overdiagnosed and overdrugged population, and we have hundreds of thousands of deaths over the decades, more than 100 million mental and physical cripples over the decades. I cannot think of any bigger disaster on healthcare than psychiatric drugs. It doesn't exist. It is incredible that the leading psychiatrists cannot see what they are causing. I just don't get it. So what do we need? We need detox clinics everywhere. We have far more legal drug addicts than street drug addicts. We need these clinics. We need, there will be questions later, didn't you hear that? We need these detox clinics everywhere. And we need psychotherapy. It actually is a good treatment that learns people how to cope with life difficulties. A pill just numbs your feelings. It takes away your thoughts. If it's an antipsychotic, you don't learn anything, quite on the contrary. So psychotherapy also seems to have better long-term outcomes than drugs, which is not surprising, as drugs have very poor long-term outcomes. And then we should ban forced admission and forced treatment in all nations. International convention. Could you please? No, I want you to leave the room now. Please, I want you. Could you escort that?
Thank you. Sorry, I'm just gonna have to ask you to hold it down until we have questions. I appreciate you're feeling quite emotional about what you're hearing. I understand that. There are many people in this room will be as well. But in order to make things move smoothly today, we do need some kind of order. So if I could ask you just to hold it back till questions, we'd really appreciate that. Okay? Thank you. Okay, please.
Forced admission and forced treatment cannot be justified scientifically. It's harmful. It can't be justified ethically. It's discriminatory towards people with psychiatric problems compared to other people with handicap. And it cannot be justified legally either, because you discriminate people in front of the law by having separate laws for people with psychiatric problems. And the United Nations Convention on handicapped people says clearly that all nations must ban all laws that allow forced admission and forced treatment. All countries in the world, as far as I know, have ratified this. No one, not a single country does anything, and we must work on this with our politicians. It's only Could you please leave the room, honestly?
No, I will not.
I was invited to speak. You were not invited to speak.
I'm a voice. I'm not just a patient, I'm a voice. I'm a person.
Right to protest.
I have a right to protest against this. Against humanity. This degradation against humanity. Which is worse than the Holocaust. It is worse than the Holocaust. We need to fight to change the laws. We need to unite. We need to unite in America and in Europe to change the laws that give the rights of these.
Okay, thank you. Look,
These crimes against humanity.
thank you. Look, I did ask, please. We do need to get through the proceedings today. I understand you're emotional about this. Why don't you and I have a conversation about this after today's presentation? But I really would appreciate, for now, if you could please allow Professor Gøtzsche to finish his presentation, because, thank you, there are a lot of people in this room that really want to hear him today. So come and see me after, and we'll have a conversation, and hopefully I'll be able to address your concerns. Is that okay? Are we agreed? Yeah, okay. No, thank you, but are we agreed on that? Yeah, thank you. Okay, all right, well, we'll talk later. Sorry, Peter. Thank you.
I don't know how I can go on from here, because I'm being interrupted all the time.
Well, we've had an assurance you won't interrupt, haven't we? So, okay, let's stick with that. And Peter, if you can, we really appreciate you continuing.
Okay.
Thank you.
This is one thing I want to work on, and I gave my first talk on forced admission 2 days ago at a similar meeting in Copenhagen. I have a strong chapter in my new book about banning forced admission. There are very strong arguments for banning it. It's only when you send soldiers to war that you do something against their will that might kill them. And in psychiatry, we cannot allow this to happen. And I have a website where I publish various things where you can follow what I try to achieve. So it's called Deadly Medicines. And now I will end by showing you what I was sent yesterday by an Australian friend. And I know the father of this person, whom I met in Australia. He wanted me to read this aloud, the father. My name is Garth Daniels. I live in Melbourne, Australia. Over many years, I've been so-called treated involuntarily at several Monash University teaching hospitals. My prescription drugs were mostly administered over and above the manufacturer's recommendations. That's because they don't work, and then people increase the dose. I also developed neuroleptic malignant syndrome, which is highly lethal. He survived. The most excruciating reaction I experienced was the manifestation of violent akathisia, where you cannot sit still. In November 2014, I was shackled in a 4-point restraint to a bed for 69 days. This is torture. My prescriptions were a combination of drugs, which including 80 milligrams of Valium, diazepam per day. In May 2015, I was again shackled for 45 days and more polypharmacy coupled with intramuscular injections. On 22nd August 2015, I was given the first of 9 electroshock treatments without my consent. Electroshock doesn't work for schizophrenia. After which I was released from restraint. I desperately want to taper off these horrible drugs that have caused me permanent brain damage. I regard my treatments as a crime against humanity. Now they want to give me clozapine, which is also a dangerous drug, for which I have refused consent. I have 2 questions. Does anybody know a good international human rights lawyer? I have no alternative but to take my case to the International Court of Justice in The Hague. His father has studied law in order to discuss with the lawyers that have been flabbergasted about this person having a father that knew the law better than they did. But still he hasn't won in Australia. I regard my treatment as state-sanctioned torture. I would like to be treated in a drug detox center. I cannot find one in Australia. How do we start one? There are thousands of Australians in my position. The last things I want to say before I stop is that general practitioners are those who prescribe most psychiatric drugs, 80 to 90%. The psychiatrists don't even know how to use them safely. So what about the GPs? They know even less. So one of my proposals is to put a ban on GPs and any other doctors and psychiatrists using psychiatric drugs. That would mean a dramatic decrease in the usage of these drugs and a much healthier population. They are far too dangerous to leave to GPs. And the other thing I wanted to tell you is that I published a pretty direct paper in the Daily Mail 3 days ago. And I collaborated with a journalist, Jerome Byrne, who is here today, I was told. And I think it was Byrne who introduced this ending of my article, which I happily accepted, that we have now launched a war against psychiatric drugs. And this war against drugs is incredibly much more important than a war against narcotics, because very few people die because of narcotics compared to all those we kill with psychiatric drugs. So let us not focus so much on street drugs in the coming years, but on psychiatric drugs. Thank you.